Welcome to the deep dive. Today, we're tackling something really important: how clinicians figure out what's behind gradual cognitive decline, or GCD. We're not talking about a sudden change like from a stroke. This is that slow, kind of creeping impairment. It affects memory, sure, but also behavior, making decisions, even finding your way around. Our sources today basically lay out a clinical roadmap. It's like a flow chart, guiding doctors from the first simple screens all the way to complex brain scans. Pretty detailed stuff. Okay, let's unpack this. With so many possibilities, tumors, fluid on the brain, different kinds of dementia, how do clinicians actually pinpoint the real cause?
Yeah, it's really a masterclass in differential diagnosis. The big challenge for the clinician and for us today is figuring out which specific neurological condition, or maybe hopefully a reversible cause, is actually behind it all. We really have to start with a kind of triage, looking for those potentially reversible things first, the low-hanging fruit, so to speak.
Right, let's start right there. So a patient comes in, maybe the family's worried about memory or personality changes. What happens in that initial evaluation? You mentioned history, exams.
Exactly. You need a really focused history, a physical exam, and then those cognitive screens you mentioned, the MoCA key or maybe the MMSE, they give us a baseline.
And what are you listening for in that history? What are the red flags?
Well, you're looking for patterns, really. Are they missing important appointments, forgetting things they always used to remember? Has their personality shifted? Maybe they're more impulsive or unusually aggressive. Are they struggling with tasks they used to handle easily, like managing finances? That points to executive function loss. Or maybe issues with spatial things, like parking the car becoming difficult or navigating stairs. Those are all clues.
Okay, so the screens kind of confirm if there's a problem, but the history helps point towards what kind of problem it might be. And I gather one of the absolute first things to sort out, maybe the most critical distinction early on, is something called pseudodementia.
Absolutely critical. You always have to screen for depression, because depression can look a lot like cognitive decline. Someone might have trouble concentrating, no energy, no motivation, memory feels fuzzy, they might seem sad or just flat. That's pseudodementia cognitive issues caused by major depression.
Okay, wait, so how do you tell the difference? That sounds tricky.
The crucial clue, the thing that really changes the whole diagnostic path, is the timing. You have to ask, what came first? If the depressive symptoms, the low mood, the hopelessness, the lack of energy, if those started before the memory problems really kicked in, you strongly suspect pseudodementia.
Huh. So if someone says, I've been really down for months and now I can't remember anything, that points towards depression being the root cause.
That's the classic picture. Because with, say, Alzheimer's, often the cognitive changes start first, and then maybe depression or anxiety follows as the person becomes aware of their difficulties. In pseudodementia, it's like the mood and motivation system breaks down first, and that causes the cognitive symptoms. They often seem withdrawn, hopeless, maybe don't even put much effort into the memory tests.
That lack of effort itself is a clue then. And nailing that distinction is huge because you said pseudodementia is reversible.
Totally reversible. If it's pseudodementia, you treat the underlying depression, usually with a therapy, maybe SSRIs, and the cognitive symptoms improve or resolve. That's a massive win.
Wow. Okay, so that's why it's step one.
Exactly. And right alongside the depression screen, we always do some basic lab work, mandatory TSH for thyroid function and vitamin B12 level.
Ah, other reversible causes.
Yep. Hypothyroidism and B12 deficiency can both cause cognitive impairment that looks like dementia. Simple blood tests, easily treatable conditions. You have to rule those out before jumping to neurological causes.
Makes perfect sense. Check the simple, fixable things first. So let's say we've done that. Depression isn't the primary driver, thyroid's okay, B12 is fine, but the person definitely has cognitive impairment. What's next?
Now we pivot. If it's not those reversible causes, we have to assume it's likely a structural or primary neurological issue. And that means brain imaging, usually a CT scan or more often an MRI.
This is the big fork in the road then.
It really is. We're looking for any abnormalities other than just general brain shrinkage or atrophy that happens with age. Simple atrophy usually points towards the primary dementias we'll get to later. Anything else we see on that scan sends us down different paths.
Okay, path one. What if the scan shows a mass?
Right. If there's a mass lesion, well then a tumor is the most likely culprit, especially if it's in the frontal or temporal lobes areas key for personality, behavior, memory. These patients might also have other signs like weakness on one side, what we call hemiparesis, or maybe they've started having seizures.
Got it. Tumor is a distinct possibility. Now, path two. The scan shows abnormalities, but it's not a tumor. What are we thinking then?
Okay, if there are other abnormalities, we generally focus on three main conditions: normal pressure hydrocephalus, or NPH, vascular dementia, and HIV-associated neurocognitive disorder, often called HAND.
Let's take NPH first. Normal pressure hydrocephalus. What does that look like?
NPH is known for a classic trio of symptoms, often called a triad. First, there's progressive difficulty walking. Then comes urinary issues, urgency, frequency, sometimes incontinence, and finally the cognitive impairment.
And the walk. There's something really specific about the walk in NPH, isn't there?
Oh, absolutely. It's the defining feature, really. It's slow, the feet are wide apart, tiny little steps. It looks like their feet are stuck to the floor. That's the magnetic gait, very distinct.
Magnetic gait, okay.
And you can often test for postural instability with a pull test. You give a gentle pull backward, and instead of taking one step to correct, they take multiple small shuffling steps or might even fall.
And the scan confirms it.
The scan shows enlarged ventricles, the fluid-filled spaces in the brain. That's ventriculomegaly, but usually with minimal shrinking of the brain tissue around them, and no obvious blockage stopping the fluid flow. If the symptoms in scan fit, we might do a lumbar puncture, a spinal tap. If the fluid pressure is normal, despite the large ventricles, that confirms NPH.
And this is another one that's potentially treatable, right?
Potentially, yes.
Yeah.
Management often involves considering surgery to place a shunt, usually a ventriculoperitoneal shunt, to drain the excess cerebrospinal fluid. It can sometimes lead to really significant improvements, especially in walking and sometimes cognition. So it's crucial to identify.
Okay, very important distinction. What about the next one, vascular dementia?
With vascular dementia, the patient's past medical history usually tells a big part of the story.
How so?
You'll almost always find a history packed with cardiovascular risk factors: high blood pressure, diabetes, maybe atrial fibrillation, high cholesterol, smoking. Often there's a known history of previous strokes, even small ones.
Right. And does the cognitive decline look different?
Yes, that's key. The decline typically happens in a stepwise fashion. Imagine stairs. The person's cognition is stable for a while, then they have another small stroke, maybe unnoticed, and their function drops down a step. Then stable again, then another drop. It's not usually a smooth, gradual downhill slide like Alzheimer's.
Ah, okay. Stepwise decline. And I guess the physical exam might show lingering effects from those strokes.
Exactly. You might find focal neurological deficits, maybe some weakness, or changes in sensation, or visual field problems, or difficulty with language called aphasia, things related to where the strokes occurred.
And the imaging would show the damage.
Yep. The MRI would show evidence of multiple past strokes, infarcts, and often widespread damage to the brain's white matter from microvascular disease. It paints a clear picture of vascular damage.
Okay. And the third one in this category was hand HIV-associated neurocognitive disorder.
Right. For hand, obviously the history includes known HIV infection. How well they're doing on treatment can vary, but interestingly, you can see hand even in people with good CD4 counts, meaning their immune system isn't necessarily severely compromised.
So it's not just about the immune status. What else might you see?
On exam, sometimes there's peripheral neuropathy, numbness, or tingling, usually in the hands and feet. Maybe other signs related to HIV. But the key imaging finding is this specific pattern: consolent, bilateral, symmetric white matter disease right around the ventricles paraventricular.
And this can range from just mild problems to full-blown dementia.
Yes, it's a spectrum. Mild neurocognitive impairment all the way to severe dementia.
Okay, so that covers imaging findings other than simple atrophy. Now, what if we get to the end of that pathway and the scan really only shows, well, brain shrinkage, cerebral atrophy?
Right, so if the imaging basically just shows atrophy, no masses, no NPH signs, no major vascular damage patterns, the next critical step, the next branch point, is to look very carefully for abnormal movements, specifically movement disorders.
So atrophy plus movement problems versus atrophy without movement problems.
Exactly.
Yeah.
Let's take atrophy with movement disorders first. Here, we're mainly thinking about two conditions where cognitive decline is a major early feature: dementia with Lewy bodies, or DLB, and Huntington disease.
Tell us about dementia with Lewy bodies, DLB.
Okay, DLB has motor symptoms that look a lot like Parkinson's disease. So slowness of movement, stiffness or rigidity, maybe a tremor, often that classic pill-rolling tremor when the hand is at rest.
But isn't dementia usually a late feature in Parkinson's?
That's the crucial difference. In DLB, the cognitive impairment, the dementia, happens early. It either starts before the motor symptoms or develops around the same time, usually within a year. In Parkinson's disease, significant dementia typically only shows up many years after the motor symptoms began.
Ah, the timing again. What about non-motor symptoms in DLB?
They are very characteristic and often quite distressing. Big fluctuations in alertness and attention. People can seem fine one moment and very confused or drowsy the next. And really prominent visual hallucinations.
Seeing things that aren't there.
Yes, often complex, well-formed hallucinations, like people or animals. And another key feature is REM sleep behavior disorder. This is where people physically act out their dreams, shouting, punching, kicking in their sleep. The dreams are often vivid and unpleasant.
Wow, that combination sounds really challenging. Okay, contrast that with the other one in this category, Huntington disease. Different movements, I assume.
Very different. Huntington's is known for chorea, these involuntary, irregular, jerky, almost dance-like movements. Fidgety is how it often starts. You might also see ethitosis, which is slower, writhing movements. Sometimes it looks like they're playing an imaginary piano. Another sign is motor impersistence. They can't sustain a simple motor act, like sticking their tongue out for more than a few seconds.
And there's a strong genetic component here, right?
Huge. It's an autosomal dominant disorder, so a strong family history is common. And it often shows anticipation, meaning it appears earlier or more severely in successive generations. Behaviorally, people might also present with depression, aggression, or even psychosis early on.
And the imaging, does it show specific atrophy?
Yes, very specific atrophy of the caudate nucleus and putamen, parts of the basal ganglia deep in the brain. Ultimately, the diagnosis is confirmed by genetic testing, looking for that specific CAG repeat expansion on the Huntington gene.
Okay, so that covers atrophy with movement disorders. Now, the final category. Brain atrophy is present, but no significant movement disorder. What are we left with?
This brings us to the primary dementias, the ones most people think of first. Alzheimer's disease and frontotemporal dementia, or FTD.
Alzheimer's, the most common one. What are the hallmarks?
Alzheimer's disease, or AD, is typically a slow, progressive decline over several years. The absolute classic feature, especially early on, is episodic memory loss. Forgetting recent conversations, appointments, where they put things, that short-term memory is hit hard first.
Anything specific on the physical exam we might see?
Sometimes, yes. You might find frontal release signs. These are primitive reflexes, like the palmomental reflex, where stroking the palm makes the chin twitch, or a grasp reflex, where they automatically grasp your fingers. These reflexes are normal in infants, but disappear as the brain matures. Their reemergence indicates frontal lobe dysfunction.
Interesting. And the atrophy pattern on imaging?
It's quite specific, especially early in the disease. While the whole brain eventually shrinks, the atrophy is often most pronounced in the hippocampus, which is vital for forming new memories and the surrounding temporal lobes. That fits perfectly with the early memory loss.
Okay. And finally, frontotemporal dementia, FTD. You said this one is different, not primarily about memory loss initially.
That's right, particularly the most common type, the behavioral variant FTD. It's really characterized by profound changes in personality and behavior, developing slowly over years. You see striking disinhibition people lose their social filter, say or do inappropriate things. They might become very impulsive, or conversely, extremely apathetic and withdrawn, losing interest in everything. There's often a loss of empathy, a lack of concern for others' feelings.
So someone might start making offensive jokes or neglect personal hygiene and just not seem bothered by it.
Exactly. It can be a dramatic shift from their previous personality, much different from just forgetting names or dates.
That must be incredibly difficult for families to understand initially. They might not even think dementia.
Absolutely. They might think it's a midlife crisis or depression or just becoming a jerk, frankly.
Yeah.
There's also a language variant called primary progressive aphasia, where the main problem is progressive difficulty with speaking or understanding language.
And the imaging reflects this focus.
Yes. On exam, you might see those frontal release signs again. But the key is the imaging. It shows atrophy predominantly in the frontal lobes and the anterior parts of the temporal lobes, which are the brain regions controlling personality, behavior, judgment, and language.
Wow. Okay. We've really walked through that entire diagnostic flowchart from, simple blood tests that might reveal something totally curable, like a B12 deficiency,
Right.
all the way to these very specific patterns of brain atrophy and movement disorders that help distinguish between 5 or 6 different types of progressive neurodegenerative conditions. That's quite a journey.
It is. It highlights how systematic the approach needs to be.
So, what does this all mean? I think the real deep dive value here is seeing how clinicians use these specific clues. Is the gait magnetic? Are there visual hallucinations? Is the decline stepwise or gradual? Is behavior the first thing to change, or is it memory? It's about recognizing these patterns.
Precisely. The whole diagnostic process hinges on spotting those specific details. They act like signposts, pointing away from some possibilities and towards others. It's detailed clinical work. And maybe this raises a final thought for you, our listeners, to consider. We talked about the big difference between Alzheimer's, often starting with memory loss, and FTD, often starting with those really striking behavioral changes. Given that families are usually the first ones describing the problem, think about this. How might those dramatic behavioral changes in FTD bias a family's initial story? Maybe they think it's purely psychiatric or just a personality issue, not a brain disease. And why does getting that initial history right, despite potential biases, make the clinician's job both so challenging and so incredibly important? Something to mull over.